Not broadcasting. Okay. Implementation science for fast diagnostics for bloodstream infections and the role in antimicrobial stewardship programs. A substantial proportion of antibiotics used in healthcare may be inappropriate or altogether unnecessary, which can lead to adverse drug reactions, Clostridium difficile infections, and the development of antibiotic resistance. And one of the major contributing factors is the delay in standard lab procedures for blood cultures, anywhere from 2 to 4 days, for both the ID and sensitivity, resulting in overuse of empiric therapy. A new, faster diagnostic test from Accelerate Diagnostic can provide both a phenotypic ID and the antibiotic susceptibility test with the MICs in less than 7 hours. Effective clinical adoption can be done using implementation science, which provides action-oriented and mission-driven teamwork and enhanced communication among diverse clinical members. So the objectives of this poster is to describe 3 tools used in clinical implementation stages, describe how antimicrobial stewardship programs can be more effective with the use of implementation science, and describe how fast phenotypic diagnostics for bloodstream infections can play a significant role in reducing the inappropriate use of antibiotics and adverse outcomes. So the description of the project is that an antimicrobial stewardship program, they've been at the forefront of the efforts to curtail inappropriate antibiotic use. But with faster blood culture diagnostics for organism ID and susceptibilities, clinicians can de-escalate or target appropriate antibiotic therapy, thereby reducing days of therapy, the costs, mortality, adverse outcomes, and length of stay. The use of implementation science can be an effective method to guide clinicians in clinical adoption sessions for successful use of fast diagnostics for blood cultures in septic patients. So the company established a clinical intervention solutions team. There's a program manager who coordinates all of the activities of the other implementation specialists. There is an infection preventionist epidemiologist who conducts retrospective and prospective chart reviews of anywhere from 25 to 30 cases of current patient care continuum, overlaid with the opportunity for intervention and associated impact. There's also a data analyst that evaluates the performance data. Post-verification. We also have an ID pharmacy consultancy service to provide clinical education as needed at the facilities, a process engineer that evaluates the processes and clinical pathways. We also have a clinical business justification specialist that provides performance data, literature, a quote contract, presentations, and deliverables for the clinical coach to share within their organization. And finally, a director of clinical adoption who guides the clinical practice and the adoption of this fast phenotypic diagnostic test and associated work and information flows. So under methods and approaches during the exploration stage, readiness is assessed by a clinical intervention solution team and includes the retrospective chart review, the process analysis of the lab, pharmacy, infectious disease services, and infection prevention, and how they respond to blood cultures. A business analysis that uses publicly reported metrics such as length of stay, mortality, sepsis readmissions, C. difficile infections, and CMS penalties for healthcare-associated conditions. And following the analysis, a diverse group of clinicians are invited to the session, including ID physicians, pharmacists, infection preventionists, the microbiology staff, nursing staff, sepsis coordinators if they exist, or critical care nurses and physicians. Even emergency department physicians may be invited, information technology specialists, and finally administrators. Some of the tools that may be used are mind mapping sessions to break down silos within hospitals and develop some teamwork and collaborative data gathering of how their processes work. And then we have the teams work on process pathways for their separate areas and then report back to the team. We may develop a fishbone diagram, which is a very easy way to be able to present to administrators the efforts of the team. And then a gap analysis and an action plan with follow-up sessions to ensure full implementation. As an example under the gap analysis figure number 4, we might find that the delivery to the core lab for blood cultures is being delayed, or they're not incubating the blood cultures properly, or they're leaving them for very long extended periods of time due to lack of 24-hour lab coverage. Our blood culture identification is taking very long, more than 24 hours. Our susceptibilities are taking another 2 to 4 days to be delivered to the clinicians. We may find that nurses have difficulty contacting the ID physicians due to lack of 24-hour coverage, or pharmacists have challenges working with the ID physicians to respond to de-escalation recommendations. And then we work with them to develop the further desired states that they would like to have at their facility. Some of the lessons that we've learned is the adoption of this faster phenotypic diagnostic technology can decrease the time to critical lab results, and the use of implementation science can maximize the benefits of obtaining this fast ID and AST result for optimizing their antibiotic therapy, and also for the infection preventionists to institute isolation precautions faster for multiple drug-resistant organisms, since the standard lab procedures that are delayed from 2 to 4 days end up delaying the placement of patients who have organisms like CRE or MRSA or VRE on appropriate contact precautions. So I want to thank you for listening to the poster presentation.